Yeah, good evening, respected doctors. Today is a special day indeed. It is Makar Sankranti Day. So happy Pongal, happy Lohri, happy Bihu, festive greetings to all of you. My name is Robin, and on behalf of Juventus Lifestyle, I welcome you all to this mega national webinar on a very pertinent topic that is of interest to all of us. The topic of discussion today is newer CCBs for better renoprotection. The program is being brought to you by Juventus Healthcare Limited in association with Cochin Kidney Foundation under their initiative of nephrology, extracorporeal group, and the updates that happen periodically. And we consider it our proud privilege to have these esteemed panelists who have given us this opportunity to host them this evening. So I would like to take this opportunity to share with you that these are the people who are so famous, so renowned, they need no introduction. But however, for the sake of formality, I would like to present to you Dr. Georgie Nanan sir, who will be the moderator for this evening. So may I request Dr. Nanan sir to take this session forward. Over to you, sir.
Thank you, Robin, for the kind introduction. Since we are running late by 7 minutes, we will not take much time in introducing the whole thing. All what I want to say is that we thank Suvendis for giving us this opportunity for discussing some aspects of nephrology, and we are going to have every third Monday at 9 p.m. a talk, and will have 12 meetings on behalf of Suvendis. Today we have a very interesting session, and we'll have a quiz by Kishore. And as you all know, hypertension control is very important. And we have gone from amlodipine to nifedipine to selnidipine to now we have got efonidipine. And we have got a good speaker, Jane Thomas Matthew, to talk to us about this new molecule. I welcome Dr. Thomas Matthew sir also. I see him. So welcome to our midst. And I welcome all the speaker panelists, LMPs, and we have the PGs, we have associates, and the guests of Suvendas. And as you know, Dr. Jane Thomas Matthew is a senior consultant nephrologist now attached to Lisi Hospital. He was the past secretary of the NAK, very active member, a very good speaker, and he is inaugurating with the opening session of the Suvendas meeting for this year. Dr. J. Thomas Matthew will be talking to us about the new CCB F1 and after hearing from him, we will have a quiz by Kishore, Haran, and then we will have discussion. Without wasting time, may I welcome and request J. Thomas Matthew to take over and present your views about F4 Jan, please.
Thank you very much, Dr. Georgie and Juventus, for giving this opportunity. And first of all, one disclaimer, because the slides are not with me. So the control is not with me. So you'll have to please bear a bit, asking change in between. So, Mr. Robin, can we have the slides? Mr. Robin, can you share the slides, please? Mr. Robin, can you share the slides, please?
Give me a moment, sir. I'm just sharing.
Can we go to the slides, please? We are short of time. Okay. So let's go straight to the topic. The next slide, please. So basically, let's start looking at the antihypertensive medications that we have, and then we'll focus on the new drug. We have the diuretics, the RAS blockers, the ACE inhibitors, the ARBs, the calcium channel blockers, beta blockers, alpha blockers, the combined alpha and beta blockers, centrally acting drugs, vasodilators. We have a whole gamut of these drugs, but each of them have their advantages and disadvantages. And let's look at them briefly, and then we'll focus on next slide. Like, next slide, please. Yeah. So the first group is the thiazide diuretics, and they inhibit the sodium transport, and they are the first line. Next slide. First line of treatment for hypertension because of their effect. The JNC as well as the LHAT study have recommended thiazides as the first line of diuretics for the first line of treatment for the hypertension unless contraindicated. Next. The prototype agent is hydrochlorothiazide, and then we have the other drugs like chlorthalidone, indapamide, which are more potent than hydrochlorothiazide. Next. Loop diuretics are very powerful diuretics, but they are not the first line treatment for hypertension. They are used in addition to the other drugs, especially when there is fluid overload, when there's cardiac failure, or other non cardiac causes of edema like chronic liver disease, chronic kidney disease. So, loop diuretics, though they are effective, they are not the first line of treatment. Next. Then we have the RAS blockers, the ACE inhibitors and the ARBs. They block the renin-angiotensin system at different levels, and they lead to vasodilatation. Next. They are the first line of treatment in patients with chronic kidney disease, with proteinuria, and JNC8 says that they are along with calcium channel blockers and thiazide, they are the first line of treatment. They have, independent of the antihypertensive effect, they have cardioprotective as well as renoprotective effects. Next. Then next in downstream we have the mineralocorticoid receptor antagonists like spironolactone, eplerenone. Though they are good drugs, they are usually not the first line of treatment. They are usually an add-on. But only thing is be careful when we are adding them to an ACE or ARB because of the risk of hyperkalemia. Next. Beta blockers are indicated once upon a time they were the first line of drugs used for hypertension when metoprolol, atenolol, and all were used. But nowadays they have specific indications. Usually when there is a cardiac problem. So when there is cardiac problem, beta blockers can be used. Otherwise, they are not the first line of treatment. First line of treatment is still ACE inhibitors, ARBs, or the calcium channel blockers, or the thiazide diuretics. Next. Alpha blockers, again, good, powerful agents, but they are used as add-on therapy. Next. Same with the centrally acting agents like clonidine. They are alpha-2 agonists, again, not first-line therapy, powerful agents, but they are used as an add-on, as a second or third drug. Next. Same thing with hydralazine, direct arteriolar vasodilator. Again, it is used in combination with nitrates or other drugs in the case of cardiac failure or as an add-on treatment for hypertension. It's not, again, not the first line of drugs. Next. Minoxidil is usually one of the last added drugs because it's a very powerful agent, but again, it has side effects. There is fluid retention, so usually combine it with a loop diuretic or a beta blocker. But it is again the third or fourth drug that is used, never the first line of treatment. Next, please. Now, coming to our focus today, it's about calcium channel blocker. So, briefly about calcium. Muscle contraction is dependent on the influx of calcium from the extracellular space to the intracellular space. Now, the concentration of calcium is nearly 10,000 times higher than inside the cell. But for this calcium to get into the cell, there are channels. They are called calcium channels. And when these cells receive these certain signals, these channels open and let the calcium to rush into the cell. This causes depolarization and it causes various actions. Next. So this is just a picture of one of the types of calcium channel. It is a transmembrane channel. There are different subunits to it. I'm not going to the molecular details. Next one. So calcium channel blockers basically either prevent or reduce the opening of these channels and hence reduce the effect of these drugs. So calcium causes these calcium channel blockers causes muscle relaxation, especially in the vascular beds, in the arterial blood beds, and they cause arterial vasodilatation. Next. Basically there are two types of calcium channel blockers, two categories, the non-dihydropyridines, and they have effect more on the heart, on the SA node, AV node. They reduce the heart rate, reduce the contractility. They also are good antihypertensive agents, but again not the first line of drugs. They are more cardioprotective agents. They are useful in tachyarrhythmias, and the prototype agents are verapamil and diltiazem. Next one. The more powerful calcium channel blockers that we are focusing on are the dihydropyridines. They are mainly peripheral vasodilators, useful for the treatment of hypertension, intracranial hemorrhage, associated with vasospasm, migraines, etc. And we know all these drugs, like Dr. Georgie had mentioned, all the dipins, the nifedipine, amlodipine, cilnidipine, benidipine, azolnidipine, felodipine, nitrodipine, nimodipine, lecandipine, and the new kid on the block, the efonidipine. We'll focus on that a bit more. Next one. So this is just briefly talking about the calcium channel blockers. We have the dihydropyridines at the bottom, which I mentioned, and only three generations are mentioned here, but now the fourth and the fifth generation drugs have also come. And then we have the non-dihydropyridines like verapamil and diltiazem. Next slide. So how do these drugs work? How do the dihydropyridines work? They bind and block the calcium channels. As a result, it prevents the entry of calcium into the cell. So the calcium cannot enter the cell, vasoconstriction cannot occur. As a result, there is vasodilatation and reduction in the blood pressure. They are used predominantly in hypertension, but in other conditions like Prince metal angina, Raynaud's syndrome, and all, it can also be used for. Now, dihydropyridines are more effective on vasodilatation, less effective on the heart function, while the non-dihydropyridines like verapamil and diltiazem are less effective on vasodilatation but are more effective on the heart. So this is the basic difference between the main types of calcium channel blockers. Next. So calcium channels, as I mentioned, are the ones which let the calcium into the cell, and there are predominantly two types. The voltage gated channel. So there is repolarization of the membrane. As a result, calcium gets into the cell from the outside, and there are different types, predominantly five types: the L, P, N, and T. We'll focus on the L, N, and T types, and then the other type is ligand-gated channel, which are the channels are opened by the binding of a ligand to the receptor, which is not part of our topic, so we won't look at it much. Next slide, please. So the calcium channel blockers, as I mentioned, predominantly the L type, the most common type, is known as the dihydropyridine calcium channel. It is long acting, that's why it's called L type, activated by high voltage, and it's present in the muscle, in the bone, myocytes of the heart, dendrites, cortical neurons. It's present all over the place. Next one. Next slide. Then we have the P or Q type channels because it was initially discovered in the Purkinje cells of the cerebellum. This is another type of calcium channel. I'm just listing the calcium channels. Next one. Next slide, please. The N type, because it is predominantly located in the neural cells activated by high voltage. This is affected predominantly by our second generation calcium channel blockers. Next slide. And then we have the T type. It is designated T because of its transient activation. It is activated by low voltage and predominantly expressed in the neurons, the cardiac cells, the muscle cells, osteocytes, and in the thalamus. So these are the main types of calcium channels. And these calcium channel blockers inhibit predominantly the L type of channel in the muscles, in the cardiac muscles, in the vascular smooth muscle cells, and within the SA and AV node cells. They prevent the influx of extracellular calcium, and these act by different mechanisms. Either they deform the channels, or inhibit the ion controlling gating mechanism, or interfere with the release of calcium from the endoplasmic reticulum. So again, the mechanism of action is variable. And the first or the foremost drug which we all have used from time immemorial is nifedipine. It's a classic L-type calcium channel blocker. It's the channels which are present in the vascular smooth muscle and myocardial cells. It causes peripheral vasodilatation and dilate the coronary arteries. It's a very good drug to reduce the BP, and it is increases the supply of oxygen to the heart. It alleviates angina. So very good drug, but it blocks only the L type of calcium channel. Next one. Then we have the next generation amlodipine. It again is a very good drug, acts on the same way, but it acts on the L as well as little bit on the N type of channels also. So it has a bit more effect than nifedipine. Next one. Next slide, please. So this is the picture which shows on the left side, you can see the vasoconstriction caused by the L type of channels. So the L type is blocked by drugs like nifedipine and all the other drugs. Almost all calcium channel blockers block the L type of channel, and some them block the other channels also. So the classical drug, the nifedipine, blocks the L type of calcium channel, and it reduces the vasoconstriction. It causes vasodilatation. Now the N type of channel, it is there in the nerve endings, especially in the sympathetic nerve endings, and this is the one which causes release of norepinephrine, which causes vasoconstriction, increased cardiac contraction, and all. So drugs like cilnidipine and all block, in addition to the L type of channels, they block the N type of channels also. As a result, direct vasodilatation occurs, as well as it reduces the release of norepinephrine, and secondarily it protects the body from vasoconstriction and reduces the myocardial contraction and the heart rate. So drugs like cilnidipine and amlodipine have dual action on the L type of channel as well as on the N type of channel. Next. Then we have the latest in the armamentarium. We have the ifeanidipine, which blocks the L and the T type of calcium channel. It has a negative chronotropic effect, so it slows down the heart rate, and it on this T type of channels, as I mentioned earlier, are present in different areas. So it has multiple benefits. On the SA node, it prolongs the depolarization of the SA node and suppresses the heart rate. It reduces the heart rate as well as improves the myocardial oxygenation because it reduces the myocardial oxygen demand. Next one. It increases the coronary blood flow, attenuates the myocardial ischemia, prevents hypertrophy and remodeling of the cardiac myocyte because it reduces the synthesis and secretion of aldosterone. I'll come to it later. It improves the GFR without changing the intraglomerular pressure or the filtration fraction by preventing hypertension-induced renal damage. Then it has activities on Rho kinase, NF-kappa B, all these things. So it reduces the hypertrophy and inflammation of the renal vasculature. It reduces the renal parenchymal fibrosis. So it provides long-term renal protection also. Next slide. By suppressing aldosterone synthesis as well as its secretion from the adrenal gland by blocking the T type of channel, ifeanidipine reduces, or I mean, it increases the sodium secretion, and again by reducing aldosterone, it reduces the renal parenchymal fibrosis. It has other effects predominantly on the afferent and efferent arteriole. Now, the L type of channel is present in the afferent arteriole, so it causes afferent arteriolar dilatation. But the T type of channel is present both in the afferent and the efferent. So it dilates both the afferent and efferent arteriole. As a result, the intraglomerular pressure is reduced, proteinuria is reduced, and it is a very good drug. It protects the kidney as well as it protects the heart. Next slide. Now coming to a little bit of its metabolism, it's metabolized by the liver. So it can be safely given in patients with advanced renal failure because its excretion is totally in a different way from in the biliary route. There is no risk of accumulation of this drug in renal dysfunction. It is protein bound, so it is not dialysable. So you don't have to time it with the dialysis. And compared to other calcium channel blockers, the incidence of edema, pedal edema, is minimal. It is less than 0.1% compared to amlodipine, which is nearly 15 to 16%, cilnidipine and benidipine, which is about 5%. So it has so many other benefits also. I mean, lesser side effects also. Next slide. Now, basically, some of the points in favor of ifeanidipine, which I had mentioned earlier, compared to the conventional calcium channel blockers like nifedipine, amlodipine, and all, these drugs, especially benidipine and efferent, dilate both the afferent and efferent arteriole. And this efferent arteriolar dilatation is because of it blockade on the T type of channels. As a result, the intraglomerular pressure is reduced. If the afferent arteriole is dilated without the efferent arteriole dilatation, the intraglomerular pressure can increase and there can be increased proteinuria, which occurs with sometimes with nifedipine. But this is prevented by these newer drugs like benidipine and ifeanidipine. And it is as good as an ACE inhibitor because in nephrectomized, subtotally nephrectomized rats, they found the antiproteinuric effect of ifeanidipine is almost as good as enalapril and when it compares to the other calcium channel blockers. Next slide. So when they looked at a group of patients with for over nearly 1 year of treatment with efferent, it reduced proteinuria irrespective of its antihypertensive effect. So even if the BP did not come down significantly in some cases, the proteinuria was reduced. So this group concluded that it inhibits afferent arterial construction. Here it inhibits the or it reduces the efferent arterial constriction also. As a result, the beneficial effect of these newer calcium channel blockers are much more than the conventional calcium channel blockers. So this divergent action of this drug will be beneficial and affects the final outcome of the underlying renal disease by reducing the proteinuria as well as reducing the fibrosis. Next slide. So looking at the hemodynamic effect, the same thing what I mentioned, it reduces the pressure by dilating both the afferent and efferent arteriole. So renal vascular resistance is reduced, filtration fraction is reduced, proteinuria is reduced, and it also reduces aldosterone secretion. Next slide. Now just comparing with the other calcium channel blockers, the graph on the left side is showing nifedipine. It dilates the afferent arteriole, but the efferent arteriole is not touched. The slide on the right is on cilnidipine, the graph on the right. It dilates the afferent arteriole and the efferent arteriole to a little extent, but not significantly. Well, if you see the middle slide, ifeanidipine, it dilates both the afferent as well as the efferent arteriole. As a result, it reduces glomerular hypertension and reduces proteinuria. Next slide, please. So, in the case of nifedipine, because of the afferent arteriolar dilatation, without efferent arteriolar change, the filtration is increased, the glomerular pressure is increased. In cilnidipine, there is little bit of efferent arteriolar dilatation, so it may be slightly increased or it may be unchanged. But in ifeanidipine, because of the significant efferent arteriolar dilatation, there is reduction in the glomerular pressure. As a result, there is reduced proteinuria. So unlike the conventional drugs like nifedipine, which is an L-type blocker, or cilnidipine, which is an L and N-type blocker, ifeanidipine, which is an L and T-type blocker, it reduces the glomerular pressure and hence offers superior renal protection compared to the other calcium channel blockers. Next slide. Then it has non-hemodynamic effects also. It suppresses the angiotensin-mediated stimulation of the Rho kinase activity. It suppresses the activation of the nuclear factor kappa B, and so it reduces inflammation and reduces the kidney damage, inflammatory kidney damage. There is reduced tubular interstitial damage. So it is renoprotective. Next slide. The aldosterone secretion is also reduced because aldosterone is secreted by stimulation of the T-type channels. Now, potassium, angiotensin 2, ACTH, ANP, all of them stimulate aldosterone secretion by the T-type channel. Now, ifeanidipine inhibits this T-type channels much more than many of the other calcium channel blockers. As a result, it inhibits the release of aldosterone, and so it has anti-aldosterone effect also. Next slide. Then renin and prorenin play an important role in vasoconstriction, renal tubular interstitial hypertrophy, fibrosis, and all. Now, they are also stimulated or secreted by the activation of the T-type channels. By reducing or blocking these T-type channels, ifeanidipine reduces the renin secretion and as a result, protects the kidney in a different way. Next slide. It has role in insulin resistance also. Hyperinsulinemia and insulin resistance, which are common in type 2 diabetes. Again, overexpression of the T-type channels in the pancreatic beta cells. This is blocked by the ifeanodipine, hence improves the glycemic control and reduces the insulin resistance. Next slide. So advantage over the other calcium channel blockers over nifedipine and amlodipine because of its dual type of action, dual channel blockage. It offers better renal protection, more useful in patients with diabetes and nephropathy, and it reduces the insulin resistance. Next slide. Better BP control, more sodium removal, suppression of plasma renin release, suppression of aldosterone release. Again, insulin resistance is reduced. Next slide. Now, benidipine has a T-type calcium channel blocker effect also, but ifeanodipine is much more powerful than benidipine. It is much more selective than benidipine, so it has an advantage over benidipine. Although the mechanism of action is almost similar, it has more balanced arteriolar dilatation, both afferent and efferent, and the EGFR is slightly improved because of the efferent arteriolar dilatation and the reduced proteinuria and the filtration pressure. It has anterior and antiproteinuric effect, reduce serum aldosterone. So same thing, it has advantage over all the other calcium channel blockers. Next slide. Now compared to ACE inhibitors and ARBs, ACE inhibitors and ARB are excellent drugs to protect the kidney, but initially there can be a fall in GFR and then it will stabilize. But here, ifeanodipine actually improves the eGFR. So less adverse effects. Then ACE inhibitors, the problem of cough is there, which is not there with ifeanodipine. So side effects are also less. The EGFR reduction is less. Actually, it's an improvement in the EGFR. So this is the advantage over ACE inhibitor and ARBs. Next slide. So this graph is just showing that there is improvement in the creatinine clearance as well as the antiproteinuric effect. Now you look at the look at the lower panel. It's a proteinuria. The the graph with the holes are for ACE inhibitor, and the arrow is for the ifeanodipine. Now they are going parallel to each other over a 1 year period. While if you look at the upper slide, which looks at the creatinine clearance, there is a drop in the creatinine clearance, slight drop in the creatinine clearance with ACE inhibitor, but with ifeanodipine, actually over 1 year, the creatinine clearance improves, and this is significant. Next slide. And over beta blockers can worsen the glycemic control. Here, insulin resistance is reduced by this ifeanodipine, so it improves the glycemic control. Next slide. Then, in special situations, in elderly people, we have to be careful. We start at a lower dose. Normally, we give 40 mg per day and we can increase it. But in elderly people, we start at a lower dose at about 20 milligram per day and then gradually titrate it depending on the need. And if patients are not tolerating the higher dose, then continue at a lower dose. In renal failure, there is no need to adjust the dose because it is metabolized and excreted by the liver. And being protein bound, it is not dialysable, so you need not give it after dialysis. You can give it in the before dialysis also at a regular time. You need not change the timing based on the dialysis timing. Next slide. So just looking at one trial in India about the role of ifeanodipine, about 50 patients were studied, and 32 of them were diabetics with hypertensive, and about 18 had only diabetes, and they were studied for 6 months period, and they looked at the improvement in proteinuria and GFR over this time period. Next slide. Ifeanodipine was given at 40 milligram once daily. Now, if you look at the GFR at baseline, it was around 50, and at the end of 24 weeks, the GFR improved to 58, which is significant. The proteinuria, which is about 3 grams, 3.8 grams per day at the beginning, at the end of 24 weeks, at the end of 6 months, it was reduced to 2.8 grams. Again, a significant reduction in proteinuria. So this drug reduces proteinuria, as well as improves the creatinine clearance or the glomerular filtration rate. So it's a good drug providing good renal protection in patients with chronic kidney disease. Next slide. Then there are many trials on ifandropin. I'm not going to the details, but all of them showed that they are as good as an ACE inhibitor in reducing the proteinuria. And the advantage is it does not reduce the GFR, but in some cases it actually improves the GFR. Next slide. The same thing, there are numerous trials, which I've just highlighted a few of them. All of them comparing different anti calcium channel blockers or comparing with an ACE inhibitor. The net result is BP control is good. It is better than amlodipine, and the side effects are less compared to amlodipine. And the advantage is improvement in GFR. Next slide. So, in short, ifandropin is a potent antihypertensive agent. It has numerous effects. It reduces the glomerular hypertension and proteinuria by inhibiting Rho kinase and NF-kappa B. It reduces fibrosis. It prevents renal fibrosis. It reduces aldosterone and its downstream effects. It reduces renin and again the downstream effects as well as fibrosis. It reduces insulin resistance, improves nitric oxide synthase activity. So pleiotropic effects of ifandropin because of its T-type calcium channel inhibition along with the L-type. Next slide. So the take-home points is ifandropin is a dual L and T-type calcium channel blocker. It has superior renoprotective effect compared to the others because it dilates both the afferent and efferent arteriole. As a result, it prevents the glomerular hypertension and proteinuria. It lowers the serum aldosterone level and prevents the aldosterone-induced sodium and water retention. Next slide. And it reduces renin release from the JG apparatus and prevents the renin-induced renal parenchymal hypertrophy as well as fibrosis. By inhibiting Rho kinase and NF-kappa B, it reduces the renal parenchymal fibrosis and slows down the progressive renal dysfunction. It reduces insulin resistance, helps in glycemic control. So, in addition to antihypertensive effect, this drug has pleiotropic effects which protects the kidney and slows down the rate of renal failure. Next slide. Thank you very much. I'm extremely sorry that I couldn't control the slides because of the technical reasons. Otherwise, it would have been a bit more smoother. Because it was out of my control, please
Thank
bear
you
with me.
very much for the excellent talk and showing the superiority of efinodepin over the other calcium channel blocker. You stuck to the time. Thank you very much, despite not controlling the slides. So now we will have the discussion after the quiz. May I invite Dr. Kishore Dharan to present your quiz? Kishore, please.
Good evening, sir. Thank you for giving this opportunity to present this a few questions. And today's quiz is directly related to what Dr. Jayendra talked today, handicap hypertensives. Can I have the slides I just put in the studio? Mr. Robin, can you share the slides there in the studio? Should I share the screen? That is the next. Mr. Robin, I will try sharing my screen again.
The slides are not yet visible to us, sir.
No.
No, not yet, because it is put in the studio, but it is still not visible.
Let us try it again.
Or should I mail it to you again? Mail it to you if you.
Yeah,
So by the
that's
time
okay.
Kishore you do it, we will have the discussion, Jan. We will
Right,
have
sir.
the discussion. introduction. So, Jayan, you have told the very advantage of this molecule, and the last but one before your take home message, the slide showed all the benefits, renal as well as extra renal. So now we'll have the discussion. We'll start from Trivandrum. Sadish, you would have been using a lot of calcium channel blockers. What was the main problem? Palpitation with the other CCBs. Are you using efinidipine? And what is your opinion? Sadish, please. Sadish, are you here?
I'm put backstage. I don't know why. Now
Yes.
I'm there. Yeah, yeah. Here I am. So anyway, I have used a lot of calcium channel blocker, but I have not yet used efinodipine. I have used amlodipine, cilnidipine, and nifedipine, all of them. And the thing is that calcium channel blockers are the basic bread and butter antihypertensives that we use. I think we can use it for all patients. We don't need to stop it for various indications and things like that. So they can be continued, whatever be the problem, unless the patient has actually got hypertension. So that way, it's very useful. The cephalodipine looks very promising, but I think we have to get some more data on that, on its proteinuric effects and all the probably bigger trials, because the advantage, if it really does a lot of proteinuria reduction, and unlike asynchronous ARBs does not reduce the renal function, that will be a phenomenal effective molecule, and probably will be actually ahead of asynchronous ARBs if these effects are proven in a larger trial. That's all I have to say. I would
Thank
welcome
you.
other opinions.
Yes, Sadish, we will go on to Calicut. Thomas Matthew, sir. See, what were the main problems in your opinion about the calcium channel blocker side effect? And what is your opinion about this new molecule which may overcome many of the side effects of the previous CCB? Thomas Matthew, sir, please.
Yeah, thank you, Dr. Georgie, for the nice session. And thank you, James, for going in depth about the new molecule. As a senior doctor, I had been using antihypertensives for the last 50 years, right from revolver alkaloids to guanethidine, alpha-methyl-dopa, and every time you get a better product than the previous product. As you know, the calcium channel blockers had been found to be very good, but the newer generation, that is efinodipine, is definitely much better, and we had been using that for the last 1 year. It is available in our hospital, and many patients are taking it. They are very happy about it. The proteinuria is definitely less, and the renoprotective effect also is found to be quite useful. Of course, we have not published a paper on the effect of that, but from patient viewpoint and from the physician's viewpoint, is a better drug than the other regular calcium channel blockers. Thank you.
Thank you very much. Coming back to Cochin side, Suraj, would you like to say anything? Jithin, Paul, Joy, I see many people.
Yeah, so Dr. Suraj here.
Yes.
Yeah, so I'm a bit concerned about reflex tachycardia. So what is the incidence of reflex tachycardia with efinodipine when you compare it to other newer molecules like acylnidipine or cilnidipine? Because they block the sympathetic system in addition, whereas efinodipine, theoretically, it doesn't block the sympathetic nervous system.
No, theoretically, it does not, because by blocking the T-type channel, it reduces the heart rate. Actually, it acts on the SA node also, so it reduces the heart rate. So I have only few patients, not in, here, but when I was in Trichy, I have used it for a few patients, and nobody complained. But it was not well promoted those days. So then back to amlodipine, cilnidipine, those are the drugs which we were familiar, very comfortable with, and we continued using it. But now that we have this drug which is more readily available, I think we should try use it and get our experience, and then take it from there to see whether it is good, bad, or ugly.
Yeah, and there are numerous studies saying that cilnidipine and acylnidipine, both of them reduce proteinuria, and they are being widely used. But are there that much studies, whether there are any studies comparing efinodipine with any of these two? Because there are studies comparing acylnidipine versus cilnidipine, but are there any studies comparing efinodipine, cilnidipine?
No, comparing them directly head to head, no. But comparing it with proteinuria, no. So it's a new molecule. I think only time will tell whether X is better than Y is better than Z. But theoretically, it has other advantage, not just proteinuric, anti-proteinuric advantage, by blocking the other things, by the insulin, reducing the insulin resistance, by reducing the this aldosterone effect. It has pleiotropic effects, and it reduces the NF kappa B. So all those things may be additional, maybe 1 + 1 + 1 may be adding on to the benefits. May not be saying head to head. It may BP control and proteinuria may be almost similar. So it's only time will tell. We cannot say this over 6 months or 1 year. We might have to take it over a longer period to see what is going to happen to the long-term outcome of these patients. Because ACE inhibitors, ARBs, the moment we started, the GFR comes down and we are scared. But then long-term, it is that drop in GFR is not all that bad. So we are comfortable with that. Now, this new drug, we have to get used to it and see how good it is or how bad it is or whatever, and then decide to use it. But theoretically, it appears to be a good drug.
Yeah, thanks,
Thank you.
Jay.
Dr. Kishore, what is your opinion? You have been using a lot of CCB. What were the side effects you have seen? And what is your opinion about this molecule?
Yeah, definitely. The hypertension control is superior, definitely superior, and probably compare it to acylipin rather than when compared to the other CCBs, the hypertension control is definitely superior. And it's too early to tell about the it's limited to tell about the proteinuric effect. But then somebody whose hypertension is not controlled, I would definitely think about adding efnodipine, especially in a dialysis patient.
Yes, thank you. So, is your quiz ready, or whenever you are ready, you can tell. We will go on to Paul Joy is there. I can see. What is your views, Paul Joy?
I have only started use this recently, and the response is okay, I feel. And I would like to ask to the panelists, so what is the magnitude of BP reduction which we can expect with this drug, and what is the maximum use? They say it is 40 mg BD, or?
Yeah, up to 80 mg you can use.
80
mg. Okay. And the magnitude of reduction, like we know that Nicardia and all, we can get a good reduction, good control of BP. And how about this drug?
It's better than cilnidipine, and the drop can be as far as 20 millimeters of mercury in systolic blood pressure. It's very effective as far as hypertension control is concerned with OD dose, and to begin with, and most importantly, less edema feet. I mean, we don't see hardly any edema feet in the patients which we have used. So a lot of usage of apnodipine right away, and then it looks good. The other effects, as other panelists said, it is yet to be seen, but definitely it's a good drug.
Jain, what is the effect of efnodipine in potassium? What I understood from your slide is that it does not increase potassium compared to other. Can you make it a little more clear, please?
No, there is no significant, although it has an anti-aldosterone effects mildly, there is no risk of hyperkalemia. So
you can safely combine with other drugs.
Yes,
like
with the ACE inhibitor, ARB, it can be combined.
Especially in Vilesh, you would like to add anything more?
Other than the points which I added, I would like to add one more thing, is that the best part is can be used in dialysis patients very frequently, sir.
Yes.
As he mentioned that it is non-dialysable. It is very effective. Another arm we got to use another medication in dialysis patients with high blood pressure. The second hour, T half is up to 1.5 hours to 4 hours maximum. So it will give you an action by the patient reaches home. So it will be maintaining the blood pressure there steadily. So it is very good drug in that context as well.
Thank you, Vilesh, and I can see Sangeeta is here. Sangeeta, would you like to comment on anything? Sangeeta, please.
Sir, we don't have much experience on this, but having the antiproteinuric effect, it should be very promising, as it is already explained, and being non-dialysable. One thing I would like to ask Jain sir is, if how much should be the conversion? Like if a patient is on amlodipine, for example, amlodipine 10 milligram one day 10 milligram per day, when we switch to this molecule, what should be the value, the dose with which we start, and what should be the BP control that we should expect?
Jayant?
Sorry, amlodipine 10 is 40 of ifeanodipine.
Yes, correct.
Okay, sir.
Amlodipine equal to 40 milligram. Now, Binu, give me a minute. Kishore is ready with the quiz. Kishore, please go ahead with the quiz.
Okay, we'll start the quiz. It is directly related to anti-hypertension. The first, there's this Sir James White Black got his Nobel Prize in 1988 in Physiology and Medicine for pioneering the strategies for rational drug design. And he discovered an antihypertensive that is considered as one of the greatest breakthroughs in hypertension and heart disease treatment since the 18th century discovery of digitalis. The question is, can you name this drug? He has discovered a few drugs that are considered as landmarks, but then one is antihypertensive, and this is the first drug that came out of that rational drug design methodology.
Propranolol, no?
Absolutely right. That's propranolol. Way back, and he is also responsible. One more drug like that is very well which was widely used at that time. Cimetidine.
Cimetidine, yeah, cimetidine.
Yeah, he has discovered was behind cimetidine as well. So we'll go on to the that's propranolol, and this rational design is that the drug molecules were purposefully built instead of the earlier method of being synthesized first and then investigated for a potential medical use. Is by the drug molecule purposefully built based on pathophysiologic mechanisms. So the next question is something of the recent origin. That's which dual endothelin receptor antagonist was found to be very effective in the control of resistant hypertension by this latest precision trial. It is double-digit BP control in resistant hypertension. Then spassendan, aprocitentan, atrasentan, and cibotentan. These names are familiar, and we know most of them used in right now being used in many trials. So which drug was in the precision trial? Again,
Zibotentan?
No.
Sparsentan.
Sparsentan. Yeah.
No. Sparsentan is not a dual endothelin receptor antagonist. It is a dual endothelin and angiotensin receptor antagonist. And we know that sparsentan was it is an approved drug in IgA and FSGS now, rather than hypertension. So it is aprocitentan that is being tried in the precision trial with excellent results in a resistant hypertension. It is a dual endothelin receptor antagonist, CT and ETB. Atrasentan is actually published 2 years back as a antiproteuric drug in diabetic nephropathy by the SONAR trial. And cibotentan is being recently, one of the trials who published this is Zenith as the effect with dapagliflozin in proteinuria. And it has been in as a already existing as a anti-malignancy drug. It's an anti-neoplastic drug. And it's again an ERA, an endothelin receptor A antagonist. Thank you.
Okay, thank you, Kishore, very much. Who said propranolol? From voice, I understand. George Kurian?
Satish.
Who said propranolol?
Satish Balan, sir.
Satish Balan. Okay, sound is altered. Nobody, I can't see any face. So, okay, thank you for Kishore and congratulations to Satish. And Binu Bendran, please, any comments on CCB, side effects, and your views regarding the new molecule superiority and the application in our practice?
Thank you, Jan, for that clear exposition of this topic. Everything which you told was very clear. You said that it is a good alternative for AC or ARBs when it cannot be used due to some other reason. How true is it? Can it be used as a first-line agent instead of an ARB when you think of renoprotection?
No, I don't think the time has come to replace AC inhibitor or ARB yet. This drug has very good action. Definitely, it has some advantages over the ACE inhibitors or ARBs. So maybe time will tell that whether it can be replaced, but definitely it can be combined with them. So we can get 2 + 2, maybe 5, the benefit, because the reduction of GFR from ACE inhibitor ARB may be offset by using this drug. So because both of them reduce the proteinuria, we don't know. Only time will tell because it's a new drug, and this is not going to be like an antibiotic where you can treat for 1 week and say the results are good or bad. You'll have to use it for years together to know how good or how bad it is. So maybe it will be a good drug to combine with an ACE inhibitor or ARB because of its less side effects and the better other renoprotective effects.
And
Thank you, Jan.
the bradycardia produced with this particular drug, is it too significant to be not used with beta blockers?
No, does not cause bradycardia. It does not. It's just that it does not cause tachycardia. So there's not
Yes.
much significant reduction in the heart rate. So again, all these things we have to titrate it depending on the patient and then see, but it's not very significant. The heart rate, it's not that it causes bradycardia, it does not cause tachycardia. That's how we
Yes.
have to look at it.
Thank you, Binu and Jayant. Lastly, we have Jidin is here. Jidin, you would like to comment anything? Jidin, please. Jidin Kumar. Okay, so it is almost 10. We have nothing in the chat box. I don't see anything in the chat box. So anyway, it is 10 p.m. And before I wind up, let me ask you a question. Is this platform good or the Zoom? What is your opinion? So I see it is the first time we are using, but I thought it may be a good platform. But what is your opinion? We
Okay,
had this problem with Microsoft and we gave it up. So opinion, Jan, please.
personally, I would go for Zoom because we are very comfortable with it. We are used to it. This a lot of hiccups. I mean, I couldn't present properly because the slides were not in my control, and I had to keep on changing it in between. So the flow of the talk is totally lost if somebody else is controlling the slides. And Zoom, we are comfortable with it. This may be better, but maybe as we get used to it, we'll we'll be able to. All of us have a learning curve, so this may be
Yes.
part of it.
I
But
had to think 3 times. That is why I'm
Yes.
telling. What about others? And I
I think
got
I
Zoom is
also
better.
feel,
Zoom is better.
yeah, so
I
Zoom
got
Zoom is
is
two
better.
definitely
messages
better.
saying that
Yeah,
there is difficulty in logging in by 2
yeah.
members.
I mean,
I think we should be Zoom.
The fact that Jayant could not present according to his wish means that it is not useful.
Yeah.
Okay, so we look into that, and so thank you all very much. Thank you, Jan, for a very good presentation about this efinodipin. And this is a good molecule, not only from control of blood pressure, but decreasing the fibrosis, renal parenchymal fibrosis, reduction in proteinuria, where there is no tachycardia, and also it has got insulin resistance decrease and better control of sugar. So a lot of advantages. Is a very promising drug, and this is a new molecule. Maybe after 6 months we can again meet and then discuss our views on this new molecule, and we can discuss much more. Thank you, Kishore, for the quiz, and that was also very interesting. And thank you, Thomas Matthews, sir, for coming and sharing your views. And we request you to continue to grace these occasions every month. We have got now almost every Monday the meetings. And before I wind up, let me thank the Suvandas, especially Robin Nath, Anit, Sadiq, and Vaishali for all the support and help you are giving. See, finally, what I have to tell is this is a platform for people for speakers to exhibit their talents. Like last time, I made a comment that Dr. Sadish, he made an excellent slides. Forget apart from the good quality of the matter also. It is also a good opportunity for the moderator to present his talents, and also for other members to ask the questions, comments to be given, and make this meeting very lively and interesting. All these are recorded, and so we can share this hopefully in the coming few weeks. And we want more participation from the audience. I will talk to Robin about that. However, there's nothing in the chat box, nothing. So I understand so many people are there. I cannot see who all have attended who all are there in the webinar. So nevertheless, I suppose there are a lot of people who have attended this meaningful discussion about a very good promising drug and which is in the market. And with this, also I'm very happy to announce that next Monday, 9 p.m., we'll have a talk on hyperphosphatemia, control and management, newer trends by Jiten Kumar. And thank you all, and let me hand over to Robin to say the vote of thanks. So his concluding remarks. Robin, please.
Thank you, sirs. Thank you, all our speakers, for the excellent contribution in making this a grand success. We actually didn't realize that more than an hour has been passed, and that speaks about the keen interest with which more than 350 people from different parts of the country on this festive day joined here. So that speaks about the acceptance and the interest of the people in knowing more about the newer CCBs, and in particular knowing about FONEDP in vis-a-vis the other molecules. Yes, sir, as you mentioned, I could see there were a couple of queries, particularly they wanted to know FONEDP versus cilnidipine as such. So how do you find both the molecules in your clinical practice? And if there are any significant points in terms of the efficacy part and also in terms of the edema part, which some patients, according to them, have the problem. So that is one significant question which I thought at the end of the deliberations, I would like to request the panelists to probably.
No. Time is 10 o'clock. We have to stop. We can say a vote of thanks, and we will discuss in the next meeting.
Right, sir. Thank you so much. So, on behalf of Juventus Lifestyle, I would like to express our sincere thanks, and it's a proud privilege for me to confer the vote of thanks. So, I begin by thanking all the members, esteemed members of the Kidney Foundation who have given us this opportunity, the extracorporeal group, and also our audience who have been there kind enough to be with us and listen to the deliberations. Thank you very much for sparing your time to be with us this evening. And we at Juventus feel happy to have you here on this platform, and in the subsequent meetings too. We will have very interesting topics coming out, and this group of experts will deliberate on those topics. So look forward to having you with us again. Thank you very much.
Thank you.
Sir,
Bye.
everyone. Thank you.
Bye. Good night.
Good night, sir.